Let me get you to turn and face me a moment. So what I'm going to do now is just to see how you are for balance. So if you stand on your right leg for me, okay, and then bring the knee up, that's good. Okay, just hold it there. You do that, we're not going to do it now, but you try and hold it for at least 20 seconds. Okay, and then we switch legs around. And what we're looking at here is your ability to keep the pelvis level and whether you're compensating by bringing your knee across, which you are a little bit there. Okay, and then down. Okay, and then we'll do that again, but this time we're going to do it with your arms above your head. Okay, so that's it, and you can move your arms around. You make it a little bit more challenging, just checking the proprioceptive activity going on in the foot. Okay, and then switch legs around. Okay, and we can see a bit more activity in this right ankle. And yes. I think, am I right in saying you've injured that ankle? Yeah. What did you do to it?
Fractured my ankle.
Okay, and did you do a lot of rehabilitation afterwards? Did you do much balance work?
Quite a lot, yeah.
Okay, but there's still some subtle difference. And there's also a lot more tension on that left side. Where you were on crutches for a while?
Yeah.
Yeah. So probably you're walking around putting a lot of extra weight through that left side, which could explain why there's a lot of glute tension and on that left side. If you take a step, sorry, if you, I'm going to get you to do a sort of lunge movement because I want to see what happens when you do a lunge. Okay, just go back. Just do that once more with the left one, and you can bring your arms above your head when you do it. Just go back. Because what you're looking at here is a bit more dynamic. You're just looking to see how much the knee drifts in. Okay, and then we'll do the same on the other one. Okay. Yeah, you can see on that right side.
Much bigger.
Yeah, quite a valgus drift. And probably what's happened there is because of the ankle injury, it's had a kind of kinetic chain effect, and you've probably got some weakness and lack of control up on the pelvis there. Okay. You can do all these sort of other tests like drop tests where you have a little low step and you make it a bit more dynamic, and it's actually quite good to film people. You can use things like Dartfish and some of these other apps, and then you can slow it down and show the patient. Okay, right, come and lie onto your back for me. Sorry, give that. So we're just going to do a bit more of a joint assessment before we start looking at how tight muscles are. So bring both knees up. I don't normally worry too much about leg length in the non-running population, but because a leg length difference in a runner can be magnify the forces, I do have a quick look at that. So just bring the bottom off the table and drop down. And again, we're not worried unless it's significant.
Okay. What's significant?
Well, probably more than 5 millimeters.
Okay.
And that is probably, I'm not measuring it. If you that's probably a couple of millimeters. If you want to be really specific about it, you take a tape measure from the ASIS and down to the lateral malleolus and take a proper measurement and do both sides. It's controversial whether trying to make everything equal and look nice, but again, in a runner, if everything else does not work, then it might be worth doing that. So now I'm just going to assess the sacroiliac joint. So I'm doing some springing on that to see how tight that is, and it's pretty tight on this left side. And while I'm here, I'll do a testing on the hip. So I'll do the Fadir test, so femoral internal rotation, and just try it in different positions, just to see if there's any sort of catching. Okay, I'll do the same the other way. We'll do the Faber test. Okay, and you see that's quite tight through there. But also, as we're looking at the iliotibial band, we would do the Noble test. So we would basically take the knee into flexion, and at 30 degrees, if there were some irritation of the Kaplan's pad, we'd probably feel soreness and maybe a little bit of catching, a bit of thickening there.
What are you palpating while you're doing that?
I'm doing it over the attachment point.
Right. Could you do that on the other leg so the camera can see that?
So basically, try and find the point in here, and then you're just extending the knee and then going up to about 30 degrees, and you're just basically feeling if there's any catching or pain. Is it sore in there, or is that okay?
That's okay.
Yeah, you haven't actually got ITB, so wouldn't expect it. But that's the Noble test. And you can, in this position also, you can, for retropatellar pain, you can actually start doing some apprehension tests on the Clarke test, where you're basically seeing how much glide there is. And again, with retropatellar pain, you'd expect that to be very tightly bound. And you're looking at how much glide there is. When you see retropatellar pain, quite often you can barely move it.
Yes.
And so I would do the joint assessment, and then we'll look at how tight you are.
So retropatellar pain, and you find that doing that Clarke's test, you can barely move the patella.
Well,
what do you do about it?
Well, then you start doing all the soft tissue work and working it. Because actually one of the biggest predictors of retropatellar pain is actually tightness in the quadricep and the rectus femoris. So working on that muscle quite often releases a lot of the patellar tightness.
Okay,
So basically in this position, we'll start off with just do a little assessment of different muscle groups to see how tight things are. So if you lift this leg off the table, try and keep the knee as straight as possible. You should at least get up to about 80 degrees. Okay, so that's good. And then down, I didn't measure that, was probably about 60, wasn't it? And then do the same on the other one. Okay, so there's quite a lot of difference there, isn't there? So there's this tension down this left side, which again, I think, as I said, I think it might be related to when you're hopping around on one leg. Okay, so I'm going to get you lying on your tummy, and we'll look at, see how tight your quadricep muscle is. So what we're doing here is just bringing the knee up, the foot up towards the buttock. Okay, so I mean, most people can't get the buttock on the heel on the buttock, but it should be less than about 5 inches. So do you do much stretching on your quadriceps?
No.
No, okay. I think you can see that. Okay, and then switch legs around. And that one is even tighter. So you can see a huge difference. So you're quite a long way. So there's a lot of tension in your anterior compartment. You haven't got any symptoms at the moment, but I would recommend that you do some stretching on that, because there's things that you need to get right, which will help you prevent injury. I know you're not doing a lot of running, but accumulatively this difference could end up being a problem. So while you're in this position, you can also do a little glute activation. So I'm going to get you to lift the leg off the table straight. Well, not just yet. So what I'm feeling here is the glute and the hamstring. So what should happen is the gluteal muscle should tense first, followed by the hamstring. So if you lift that off, okay, and down, and then we compare it with the other side. Okay, so it's a bit subjective, this test, but I can tell you that this tightens up much more quickly than that side. So that's sort of reinforcing this tension down this side, which I think, as I said, I think it's probably come about from having put a lot of extra weight through this side. So we've got a proprioceptive problem on this side, and we can see that from the balance that is wobbling around a bit, because you need to do a lot more exercise than you think to get all the proprioception back. It always takes a long time. It can take up to 12 months quite often.